Welcome to the Life Science Success Podcast. For those of you who don't know me, my name is Don and I'm a consultant in life sciences. I help companies manage complexity and increase performance. Today on the podcast, my guest is Andrew Norris. Andrew is the co-founder of BCN Biosciences, a recent startup that has projects ongoing in the oncology drug space. So with that, welcome, Andrew.
Yeah, thanks for having me.
Yeah, thanks so much for being here. So would you mind telling the listeners just a little bit about yourself?
Yeah, about myself, I was born actually in United Kingdom, moved to the United States at the ripe old age of 1.
Oh, wow.
Yeah, and my dad was an engineer. We moved originally to Michigan, and he experienced one winter there and immediately came down to California and signed on with an aerospace company. And they went under in 12 months on a contract, government contract, and then, which interestingly enough is maybe a couple miles from our center, BCN Biosciences, and that's it. I mean, he joined Unisys, but we grew up in California, and I just about my educational background, got a BS in biochemistry, a minor in biotechnology, and then did a PhD at UCLA between molecular and medical pharmacology and chemistry, UCLA chemistry.
Yep.
And the people that were mentors of mine, one Mike Jung, who is a brilliant synthetic chemist. I had a PI who was Tatsushi Toikuni, a Japanese synthetic chemist, and also Mike Phelps, long
The
time.
swimmer?
Yeah, he invented PET.
Okay.
Yeah, Mike Phelps in the Department of Pharmacology. He was a chair.
Okay.
So a long history with him, among other people at UCLA. And there, my focus was development of small molecule, either inhibitors or activators, antagonists, agonists, et cetera, principally focusing in the oncology space. So I had quite a it's interesting because it was on the fence between the biochemistry side and then making molecules to interrogate, and then the pharmacology, and all that brings me to where I am now. Principally focused in the oncology space, but making small molecules against select pathways and targets.
Yeah, so whenever I read your bio, it was interesting to me that I saw that you also work in a variety of companies, because whenever people look at my bio on LinkedIn, I would imagine they sort of shake their head going, okay, so where does this guy actually work? Where does he spend all of his time? And, I have, clients that I certainly spend a lot of time with, but then in addition to that, I have, these other companies that I run, as well. And I saw a similar sort of story on your side. Can you tell us, just a little bit more about what it is that you're doing at UCLA today? And then also I saw, and I'm probably going to butcher this name, so I'll apologize to the company to get started, but is it Mid-Val Group?
Yeah,
Or Mid-Valley?
Mid-Vale
Okay,
Group.
Mid-Vale.
Yes,
Okay.
yes. I'll start with the UCLA stuff. I think what I do at UCLA. So my appointment is in neuropsychiatry, believe it or not, and I work closely with different faculty and researchers there. Very close with Professor Whiteleg there, mostly in the analytic space, meaning mass spectrometry, et cetera. And one of the interesting things is was involved with the former, he's retired, vice chair of radiation oncology. We have about a decade related project in radiation countermeasures. So what is that? So radiation countermeasures on or about the 90s. I don't know, does that date George Bush?
Yeah,
George
I'm not sure.
Bush.
I would have
Yeah,
to think through.
he did this act called the BioShield Act, and that act was meant to, which is interesting because it's now probably a more sexy topic than it was back then, to develop countermeasures and form an institution called BARDA, the Biomedical Advanced Research and Development Authority, which in the pandemic was inherently useful. BARDA basically acts like a government venture wing. So they basically go in and fund areas of immediate public safety concern. and also, Dr. Fauci, NIAID, also had their hands in this whole pot of, both focus and money. And our area, so, the vice chair is William McBride of Radiation Oncology, UCLA, basically to develop radiation countermeasures against nuclear threat. So at the time, there was really nothing that worked. One compound that the Army, I think it was, had developed through a giant campaign, which was toxic. The toxicity was level was below its efficacy level. So, needless to say, that doesn't work well.
Right. Yeah.
But it was the only thing that actually existed, and so, we developed. There was like a quite a few tens of millions of funding to undergo multi-focused phenotypic screening discovery. So we screened over 85,000 compounds, came down to about 10 real hits, and then followed on with 2 classes of drugs. And so, later on, being, someone who focused on oncology, and certainly, after 10 years, do a little bit about radiation oncology, we out licensed those assets, 2 classes of drugs from UCLA. And, we discovered their use in oncology, which is quite exciting. But that kind of covers my UCLA, and still we're back and forth all the time. I got an office there, office in Pasadena, and this has become kind of a dominating part of both the BCN program where I'm at, and then also what we're working at UCLA as well.
Very interesting.
Yeah.
Yep. And then Midvale Group.
Yeah. So this gets back to one of my mentors when I first went to UCLA was faculty in Anderson School of Business, Alan Carshwood. I got the contagion for entrepreneurship from him. He's still a very close friend, lives in Texas. And, basically, we came in with an idea, did a whole venture pitch, et cetera. And of course that fell apart. It was a thing with Dennis Lehman, who's gone on to do really successful things now. But bottom line is I met an individual there who now is one of my co-founders for BCN Biosciences, Sudeep Chakraborty. He likes to, use the name Deep for short. But, we formed Midvale both to do consulting, but also it's the entity that started BCN Biosciences.
Oh, okay.
And funded some of its initial operations. So it's more of a side vehicle to both advise other small biotech companies in the entrepreneurial phase. We've become a bit of an expert after a decade in this. And then, like I said, part of the founding. So it kind of activity there goes up and down over the years. Yeah.
Very interesting. And then what stage is BCN currently in?
The BCN is a preclinical phase.
Okay.
So we're now pivoting these assets, which are effective in nuclear countermeasures. So we can give them to animal models, just common rodents, before they, receive super lethal levels of radiation or afterwards, up to 24 hours afterwards. And those that receive the drug live. All their hair turns gray, but they live fairly normal lifestyle other than gray hair. And the controls who do not receive the drug, all of them die. So, but doing phenotypic screening, we didn't really know what the target was. So a lot of the preceding work, and then, the other thing too, is that they don't protect tumor tissue. So as I said, there are 2 classes of drugs. We call one 0 series, the other one 500 series. The 0 series is very potent inhibition of the RAS pathway through a process called P10. It's a protein restoration. And so so RAS is a very common mutation in cancer. And all RAS mutations have basically an Achilles heel, which is they suppress this P10 expression. It's involved in preventing the cells from dying. Cells usually are pretty smart. Once they sense that something's dysfunctional, they'll go ahead and off themselves, like,
Huh.
go ahead and commit apoptosis. It's a way that the body protects itself. And, the RAS mutation has to shut that down in order to, immortalize. And
Hmm.
then it will continue to acquire further mutations because rapid replication of his DNA, sloppy, it gets sloppier as it goes faster. I'm being very basic, but it'll acquire other mutations to further immortalize the cell. So it's called a driver mutation. And what we do is we target P10
Okay.
to its restoration. It's being suppressed by a particular transcription factor. So that is important. Why it's important now is there are two drugs that have been launched for a specific mutation. We refer to the amino acid sequence as G12C. So Amgen launched one, and a company, Mirati, launched one. And lo and behold, this would have been predicted if you understood the biology well. Those drugs face pretty powerful resistance, meaning that after a long period of treatment, the cancers become resistant to it. So now it's all about people throwing other inhibitors down the pathway, ERK inhibitors and MEK inhibitors, et cetera, to try to counter this effect. But they both received FDA approval. But the other mutations in RAS are harder to get to for multiple reasons. But the mechanism which we are targeting is resistant to the resistance,
Mm.
resistant to resistance, if that makes any sense. So that's why we're driving a distinct difference between the other competitors, and we are still preclinical, but the others have been working on, for example, D and V mutations, which are the others that I'm referring to. I mean, they're the biggest pool. D and V mutations in RAS are the biggest pool in the entire RAS mutation. That's like 90% of pancreatic, 50% of colorectal, almost as much as C in lung, and on and on and on. Some female cancers, etc. This resistance mechanism is even worse there. But these companies have been working on D and V inhibitors for more than 3 years, like 60 million, 100 million in the bank, and they're still preclinical as well.
Wow.
So we think that we have an opportunity here, and that's one of the things that we're most excited about. Um,
So do you
and then,
still envision that this would be something that would be given to people that receive a high dose of radiation for some reason? Or is it
I
just in
do.
general, there are RAS mutations that you guys are targeting and you see that being the focus of the company?
It's really interesting, and maybe we'll get into this a little bit later in the conversation. So, the 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 use of the drugs and radiation for oncology uh, right now, our experience is amongst investors and amongst pharma, nobody knows what to do with that.
Mm,
They draw a blank face.
sure.
They just don't know what to do with it. So although it's one of the things that I'm most excited about, is their use in radiation oncology to further its therapeutic index. It's not something that is well received in the investor community um, for various reasons. Historically, one incident keeps coming up in the conversations because we tried to pitch this. Does not protect tumor tissue. In fact, sensitizes tumor tissue and protects normal tissue. As you get into things like pelvic radiation, for everything from prostate to you know other abdominal cancers, etc. Um, you know, the only difference between Crohn's disease and these patients is that we know we're giving it to them.
Hmm. Right.
So you
Yeah.
got Crohn's disease, of which there are some one or two drugs that palliate Crohn's disease, but for individuals who have pelvic radiation, they will have dysfunctional bowel function. Um, and it's also a dose limiting event affecting tumor control. So when you get, bloody diarrhea, things like that, they're going to take you off therapy, which affects your tumor control. Amgen developed a drug called Capivance a long time ago, and it's a growth factor, which growth factors can be very dangerous. You have to be very careful about their behavior on tumors as well, because tumors love to, harness the power of growth factors. And bottom line is that as a researcher in, I don't know, Scandinavia somewhere, they figured out that Capivance had induced the growth of several tumor cell lines. So the FDA quickly put some mandates on Amgen.
Hmm.
Amgen shut down the program, divested the drug, got rid of it, and since then every VC is scared to death to even go that route. But for us, we're not even related to that biology or anything. But it just really kind of poisoned the water. So we strictly talk about the oncology focus, but I do believe that in approval in oncology, we can definitely pivot and run trials on reduction in we call it barrier function, damage to barrier function, and or this what do we call it? What they call it, radiation bowel syndrome. And the same with chemo too. We've shown that it has the same effect with chemo,
Hmm.
and there's a mechanism behind that, why that is. So it's actually
Very,
quite basic.
very interesting. I mean, it's yeah. I mean, I've worked previously for GE Healthcare, and they had, different devices like PET devices and things like that for, radiation treatments and things, and then you kind of, fast forward to now, and look at all of the different drugs that are coming as well as all the ones that are, currently working. It would be, amazing, I'm sure, for those patients to have an option, right? Because I mean, so many. I even have family members, right, where they've said, "Look, in your lifetime, you've reached your lifetime amount of radiation. You essentially can't come back. There may be other treatment options for you, but they start to get more and more limited as you go along."
Yeah,
And so I just look at the idea of having drug possibilities that can support these patients as well.
it's amazing. We listen to Sanofi, Sunrise, venture arm of Sanofi, saying that we got to get into supportive care. We got to get into supportive care, and we just kind of see this from the pharma community like an intellectual interest, but kind of scared to move
Mm.
on something. And the both from chemo and radiation, the mechanism is very very simple. Is that radiation and chemo, cytotoxic chemo, work based upon
Well, I'm
yourself.
wondering.
I know
You
my
your internet
froze.
paused for a second. Yeah, you
Yeah,
froze for a second. Sorry about
sorry
that.
about that. Did you hear me though? Did my voice cut off or?
I think your voice stopped as well, but
Okay.
you were talking about Sanofi and other drug companies.
Yeah. So the thing is that for the mechanism is very simple, and that is that radiation and cytotoxic chemo work by targeting rapidly dividing cells. So cytotoxic, you have like chain terminators, alkylators, et cetera, of DNA, affecting microtubules, so you can't divide the cell, et cetera. But the only and radiation the same, cells that are dividing are more sensitive. Hence, Roy Coates, Dr. McBride's mentor at UCLA, developed this whole technique of fractionated radiation based on that whole hypothesis, right? And the thing is that you know also rapidly dividing are specific stem cells. So you notice your hair falls out.
Right.
Stem cells are really busy at the base of the hair follicle generating new hair, but also in your GI and your epithelium, in your mouth, etc. Your GI tract is renewed in adult humans every 4 to 5 days. So, a lot of cells are slothed off. And I'm not going to go into the details of what that looks like, but when you go to the bathroom, that's mostly slothed off cells. So in your GI tract, you have little crypts, right? And there's how you absorb nutrients. The base of the crypt are LGR5 positive stem cells. Well, guess what? they differentiate into all cells lining the GI tract every
Mm.
4 to 5 days. So they get deleted,
Yep.
and it affects barrier function, everything, bleeding, etc. Same with chemo. So with the drug, they're preserved, and you could tolerate more radiation, more chemotherapy. Without it, it's a tumor control issue because you have to stop therapy, produce breaks in therapy, reduce the therapy, and all that leads to less benefit for the patient. So, but nobody's interested in that.
Right. Yeah.
So,
Well, it's, I mean, I've even talked to other leaders that are doing things like, creating devices for, the neuropathy that occurs and things like that. And I mean, similar sort of story, right? Nobody really wants to kind of undergo a lot of these things that seem like peripheral things to saving the life. But at the same time, it's like, well, the quality of life can go down significantly with some of these things as
yeah,
well. Yep.
yeah. So,
So, what are some of the biggest challenges that you're facing at BCN?
I think right now the biggest challenge is funding. We have great programs that I think we've discovered a new pathway in RAS biology. We're in the process of publishing that. But also, right now, we're undergoing this pivot. So we have received millions of dollars of government funding. But at the same token, it's like we're now pivoting for the oncology portion towards, venture funding. And that's it. I mean, shaping the story, getting the key measures that they would be interested in, which, for government, there's one interest, and for, non-government, there's totally
Right.
different interest and different focus. So we've spent a couple of years pushing hard on that. But it's fascinating because, one of the things that emerged, of course, after, I don't know, 2001, 2002. So 2001, 2002, if we had the data we had now, we'd be funded. We'd be sitting on a pile of cash, I believe. But, you know, after that, it became this kind of button down in the venture community, holding on to their funds because, for example, if you put, I don't know, 100 million into a company, it's valued at 50 now. So
Right.
they all got up and started laughing, but they're just holding on to their purses.
Sure.
This current banking situation doesn't help either.
Yeah.
Everybody kind of got scared that the money that they, have in banks, especially the smaller biotech companies that are VC funded, that may be gone as well. So, but regardless, this is a very interesting climate right now. So we're doing what we can to, keep going with the science. We're, constantly speaking to the venture community about our new developments and what we're doing. And we're just hopefully by the end of the year that there'll be some traction as they start to, that's the kind of forecast. End of 2023, early 2024, things should turn around. But who knows? Maybe this SBV thing is a good thing, because it'll stop the Fed from raising rates, and then maybe, the economy will start to shift in a more optimistic look because they're not going to raise rates. I don't know, but that's our biggest challenge right now. The science is good. The people are good. I think the opportunity is huge. But yeah.
Yeah. It's,
Not uncommon for early phase biotech to say money is a challenge.
yeah. I think since last week, late last week, I've almost had nonstop conversations. Every call that I'm on, people are asking me about, funding and what do I think funding is going to be like and things like that. I said, look, I don't have really any good indicators right now other than everything was slow before SVB happened. Now that it's happened, everything more or less stopped, and we're kind of waiting for that next inflection point, showing that okay, more or less everybody's picking stuff back up again. But I mean, I know that there isn't one company that I talked to that said that they've truly stopped their efforts in terms of trying to reach out, right? So all of those efforts are still going on. It's just a matter of, look, I think most people are getting either a hard no or a, sort of a, we'll see what happens in the future as most of their follow-up. So it's kind of unfortunate given the fact that, you have to pay the bills at some point for the science that you have to generate the data. So yeah.
Exactly. And in our experience too, during the pandemic, people got really good at writing grants. So we're really good. I mean, I don't know, the past like 7 or 8 years, we pulled in 14 mil in grant money. And so plus, but, you know, lately it's very challenging because I think everybody and their brother is taking that route when the venture community ran dry. Entrepreneurs are getting busy submitting.
Yeah.
So it's definitely a survival time, but you know, and some venture sees it good. They like, you know, the stuff that shouldn't be funded because that was the kind of complaint. I just went to a meeting in San Diego. Some of the biggest venture firms there, Fraser and Venrock, and you know all those, and you know, so they see some of that as good, you know, giving it kind of narrower focus, complaining that things in 2021 should not have been funded.
Mm.
But at the same token, we also notice there's always kind of the turnaround circle jerk where there's extreme focus of the venture community where they kind of invest in what everybody else is investing in. And
Sure.
so they tend to, because they cross collateralize things and cross invest, et cetera. But it kind of reinforces a single story, you know? So it's like, we're doing only cell therapy now. You know, we don't do small molecules anymore, or, you know, antibody conjugates, ADCs, whatever. Um, but yeah, so it
Yeah.
produces these trends, which I don't know that are helpful for innovation because then it kind of gets into the same pitfalls that you see with like grant writing, you know,
Mm-hmm.
where something it's been well established that in grant writing, you don't want to be an innovator. You need to be just a little bit of spin off of what has already been done. Just hide your innovation because if you flat out say you're going to do it, you're going to get too many questions and people just throw up their hands. They don't want to fund you.
Wow.
So
Where do you see the biggest opportunities at BCN?
I think the biggest opportunity, I mean, I honestly, um, so the supportive care angle, I think, is probably the biggest opportunity. But again, we're not talking about that. Um, I'll go into that in a second. But for the biggest opportunity, I think is this, you know, RAS approach. Main reason is because uh, there is kind of an inbuilt resistance in the pathway.
Mm-hmm.
And large pharma right now is throwing a lot of money on what they call selective RAS inhibitors. So RAS is like a ball, right? It's very smooth. In one mutation, the C mutation, there's a pocket. And a guy, Kayvon Shokat, I think it's UCSF, figured out that he can make what they call allosteric inhibitors, which means that it's like a Pac-Man. You bind the back of the jaw and it can't close its mouth anymore,
Huh.
versus, you know, jam in the mouth. And so, you know, that kind of technology was licensed to Amgen. Amgen developed sotorasib on that. The market name is Lumakras, where it binds into that pocket small molecule drug and alkylates a cysteine and, you know, basically shuts down the activity of the enzyme. Um, Another company, Miriati, was right on the heels, very similar principle, binding to that pocket, et cetera. But two problems emerged after they got clinical approval: the resistance situation to the drugs, and then the DNV situation, the mutations in DNV RAS. They don't have that pocket.
Ah.
It's not a deep pocket. They don't have cysteine in there, but
Mm.
there's still like this big attempt to use the same model. And you know, to also acknowledge there are other people trying to use microRNAs and things like that to shut off RAS, but the inbuilt, because it's such a fundamental protein, the inbuilt, you know, kind of redundancy in the pathway is you have KRAS, and then you have NRAS and HRAS.
Right.
And KRAS is what they're all targeting right at the enzyme. But when you target it, the pathway starts to move to use N and H to go back down that RAS-RAF-MEK, same pathway, activated again, all to suppressing that PTEN, which then immortalizes the cells, et cetera, et cetera. So I think for us, that is the biggest opportunity that we have to, you know, validate all the stuff that we've done, and get that out there and get it funded, because I can think it'd help a lot of people. Um, and, you know, that just straight up. But then if you go to the supportive care case, the drugs do that. The one that inhibits RAS, we have a 500 series class of drugs that also don't have this RAS effect. They don't have really an anti-cancer effect, but they also don't protect tumors. We tried it in more than 70 cancer models, no protection of tumors,
Hmm.
but it protects normal tissue. And I think it's a big deal because everything from pediatric radiation oncology, you have, different treatment. They don't give the same treatment. You use very pencil beam SBRT for adults for brain tumors, et cetera. Children, they give cranial radiation. So it's a different technique. And so I've spoken to some of the lead radiation oncologists who want access to this drug. Uh, their thing is they love their career, but what they know is they're curing cancer and they're really good at it. These are kind of their words to me, not even paraphrased. I'm really good at, treating cancer and curing cancer, through radiation oncology, but they give kids cognitive deficits for the rest of their life. They
Wow.
give them growth deficits, sometimes, regionally. And they also give them cancer. So for adults, you don't see your patient 20 years later,
Sure.
most of the time, right? But for pediatric rad onc, they do. So these drugs have a tremendous effect in that arena and can, prevent these kind of things, as well as the other things that I had mentioned. And I think we just need one win in that area for it to gain traction. But like I say, it's a very abnormal conversation. So the strategy right now is to get the drugs approved in the oncology setting. And then, once we have approval, we're able to pivot to these other areas and demonstrate the efficacy. Because if you have a drug that has this powerful anti-neoplastic effect in RAS generated tumors, especially D and V, which are very aggressive, uh, the main thing is that if you are also able to impact overall survival and progression-free survival by allowing maximum tolerated dose.
You started to break up again, but I think we're gonna get you back here in just a second. Uh, yeah, I think you're back.
Can you hear me?
I can hear you, but it looks like your picture's still a little broken, but you're slowly coming back here. The This is part of doing a live internet broadcast show, right? So it will come
Yeah,
back.
yeah,
Yeah, there
exactly.
you go.
I think you can hear me now, right?
Yes.
Yeah, it's a very low image. Is funny because I got this is on cable too, so it should be pretty good. But you never know. Windows updates. Blame it on Windows updates. But what I was saying was that epithelial protection mechanism should have a significant impact on dose tolerance of the chemotherapy and radiation, hence tumor control. So despite the anti-neoplastic effect, it should have a profound effect on the delta between treated and non-treated, and allow better tumor control as an endpoint. So that was out of the conversation that I do think that is one thing I'm excited about. And then I think that certainly that when that's able to be seen, I think there'll be a rush of interest in that.
Very good. So, Andrew, there are three questions that I like to ask every guest. What inspires you?
What inspires me? I mean, I think that for this field here, in general, what inspires me is looking at talented people who are really good at what they do. I remember getting tires changed at a friend of mine's husband's tire shop, right? And I'm just watching the workers, just how fast they worked and like they could do this blindfolded. And I was like, it's inspiring. I don't care how educated you are, what field it is. If you're extremely good at what you do, that inspires me. But in our field, what definitely inspires me is being able to. You might expect me to say, "Oh, provide something to patients so they can live longer and things like that." And yes, but what inspires me more is being able to fix something that's
Mm-hmm.
broken.
Yeah.
I just like that. And Yes, it's hard. I mean, you go into the unknown, and sometimes it can be frustrating because you don't always have all the answers. In fact, in that space, you're on the front line, so you don't have the answers. But to go out and do the work necessary, pivot, think about it, go back at it, and to actually see something shift, that is inspiring to me.
Yeah, I agree
Yeah.
with you. I mean, well, I mean, to start where you started, right? So one, to see somebody do some of the amazing things that they may do in their field, even outside of science, is, definitely, inspiring. And then I think, as well, the continued innovation that happens in our field, people continually use, it seems like, similar sort of things over and over again, but at the same time, they sort of more creatively apply different levels of science to try and solve the problems that we have. And to me, that's very inspiring as well.
I'll just follow on that too, because some of what inspires people. So I British. I grew up in a British family. We all love things like Formula One, and in fact, what I didn't tell you was out of high school, I raced motorcycles for 4.5 years.
Oh, wow.
In fact, I have one that goes 0 to 60 in 3 seconds, tax at 15,000 RPMs. But my wife does not like that with a 3-year-old, but it is what it is. But it's like I in line with what I already said. Like, there's a driver. His name is Ayrton Senna, and
Yeah.
he's considered by the current drivers and the past drivers as the best of the best. And a lot of it was like just taking that whole person, like everything from the spiritual to the physical to the discipline, um, and marrying all of that to the point where people tended to make fun of him. Um, but just seeing somebody who is just all in, and many people think that knowing everything, like if you could just know everything, you could solve any problem, and it's just not true. It's not true. Sometimes it just takes effort and it takes discipline, but it's like a way of being
Right.
that it is going to happen. That really impacts performance. And so, you know, I'm definitely inspired by Ayrton Senna and that example. In fact, I studied him a little bit because in the era of performance, it was something that, actually I learned something about myself inside of that.
Amazing.
Yeah.
What concerns you?
Concerns me. I think the biggest concern is what I'd already mentioned was, that for both funding institutions, whether it be venture or I don't know that this is the case for example, angel investors, but definitely for venture and definitely for granting institutions, is this turnaround circle jerk where you and I are investors, and I ask you what you're investing in, you tell me what you're investing in, then I want to invest in that, and then you're asking your friend who's an investor what he invests in, and he's investing in that, and that's what he's excited about, and then anything else that could change the world is kind of like, we don't do that.
Right.
And I understand it on one token because for the venture community, yeah, you want to specialize in an area and you need to understand that area, and so all this flip flop of all this stuff going on, but at the same token, it really, like for the example I just gave you, the supportive care, it's like this is a global problem, like a
Right.
real global problem. Like we give people irritable bowel syndrome for the rest of their freaking life, and why? We don't have to. And someone comes up and said, I have a drug. Here's the mechanism. Here's how it works. No interest. Nothing. Just dead. And so, that I think is the biggest concern that I have. And I don't really have an answer how to shift it. I understand why they do it. But I also think that, have some, have some chutzpah, like try to at least understand the impact of something. Um, and we didn't really see that with that particular topic, so that definitely concerns me. The funding stuff, as far as the economy and all that, about every 10 years, we have a correction. If you look
Right.
back to the 80s savings and loan crisis, the dot-com bubble, the 2007, 8, whatever, real estate blow up, the pandemic, it's always like for whatever reason, we have corrections. I have no doubt will come out of this. So that doesn't, concern me as much, but it's just the habits. And I guess it is a human thing, but, you know, the funding stuff, like turnaround circle jerk, is like the biggest thing that concerns me.
Yeah, and I hear that fairly consistently with companies that I know are supporting drugs as well. I mean, they just on the devices side, people I think can get it a little easier. And then whenever you get into diagnostics, again, you're starting to talk about chemistry and how things react and stuff, and people just get lost somewhat in the science. And so telling that story in a very basic way for people that probably aren't close enough to the science, to make that decision. We've seen that same whiplash with other companies that I've interacted with, and I've also seen where a venture capital firm will completely bypass the science for the story. And
Yes.
I mean, there's a part of this, guys, that, I mean, you've got to understand, I'm sorry, the science. And if you can't understand it personally, go hire somebody that does. Go hire, somebody that can dig into the details and understand exactly what it is, what are the benefits of this, and what is the downside, because there's always a downside. And
Yeah.
what is the sort of the reasoning that the company that you're talking to chose this pathway? Because I mean, again, whether it's diagnostics or it's treatments, I look at it as you're trying to thread a needle, a very tight needle, and with that there's ups and downs with all of it. And I would hope that as we continue forward, more and more companies get smarter about the science as well, and especially the ones that are in our space.
Yeah. It's funny you say the story because I remember speaking to one venture capitalist, and he says, we have to be careful. I was like, why? He says, because, there are people that are really, really good at telling a story. They know exactly what we want to hear. They got
Yep.
the perfect presentation, the perfect story, perfect everything. And, but yeah, they're not producers. And it's, many times it's the guys that are nerds. They have bad story writing skills, and that's where the real value is. But you have to tease it out and work for it. So, um, it's harder there. So,
Yeah.
and certainly people that do science tend not to be the best storytellers um, at all. They're just into data, something
Right.
that is not easy to explain.
Absolutely. Thank you for sharing that. And then what excites you?
Excites me. I mean, I definitely I had an experience the other day. So, there's certain things that you know our people do right in labs, et cetera. But then there are other things that I feel like I need to do myself, right? So a lot of times, if we're testing a drug and there's formulations that need to be done to make sure, because you get a really good drug, and if it's not formulated properly, it just doesn't work. And it's not just that you're wasting animals, it's that when something doesn't work for the first time, it's not like people go, oh well, you should try something different. A lot of times people with a stake in the business are like, it doesn't work, and they just, that's it, you're done, just wrap it up, kill it, right? And so it can be very dangerous. So I tend to get my hands involved in that. And we had one program that had a lot of problems with both the synthesis and the drug, et cetera, and the formulations, the whole thing. And, what excited me was I was able to think about the problem, concept a new drug, source the reagents, and I went in and I freaking did it myself and I nailed
Amazing.
it. And I was like so excited, to see like this. I hadn't done synthesis in like 20 years, right? So I'm like looking at the single TLC spot of a product. I'm like, right? And the chemist give me the NMR. He's like, that's it. I'm like, oh my God. It wasn't a complicated synthesis, but we have, I think, 8 or 9 years of problems with the drug, with the preclinical academic version of it, and several restarts and alternate. But those were all learning steps, and that's how we rose at the new molecule. So those kind of things is kind of in line with what I was sharing before. Is that if there's a problem, I love to fix problems. I don't know. It's just something that turns me on, you know. So
Yeah, I thought you were going to say going fast. Driving fast was
that
on
too.
your lists. Yeah.
That too. Yeah, no, I definitely like going fast, but I have to be careful.
Yeah.
That's one thing. If you notice people that have raced, they definitely behave different on the road than people that have not. People that have not, and it's one of the things that I often warn people about. There's a, you know, an as lived experience, and then there's a head knowledge experience. And the head knowledge experience, people can be dangerous because
Mm.
they really believe in themselves and they think that they can, do things that maybe they can't. Um, okay,
You're
back.
you're
I
you're
think.
back.
Yeah, in chunks here. I'm
Right.
back in digital packets. Um, Sometimes if I don't move as much, it may not transfer as much data. But you know, anyway, so they 9 times out of 10, I think that sometimes they think they know more than they do, and it's just subtle moments. If you have race, you behave very differently on the street. I don't know if you can still hear me.
Yeah, it's
Nope,
kind of coming in very digital
it's
on
not.
my end as well. It's slowly trying to come back, I know, as a part of the the catch up process. Oftentimes the packets do.
Interesting.
Maybe if I talk for a second, it'll catch up there. There we go. Seems like you were there.
which which is interesting because I have no break in you, but I could see a definite break in me. So
Yeah.
it's uh I guess it's on my end. I don't know. Whatever. I got to talk to whatever the Time Warner and something else now. But yeah. But at any rate, yeah, going fast does excite me, but in
Very
certain contexts.
very good.
And
Well,
yes, when
Andrew,
I get on the freeway, sometimes I will lean it at 45, 50-degree angle.
in
Believe it or
California,
not.
that would be a little challenging at times, I'm sure.
Yeah,
Yeah.
exactly.
Well, Andrew Norris, thank you so much for being here. Thank you so much for being on the Life Science Success Podcast with me and sharing your story about BCN and your career and everything that you have going on. So thanks so much.
Thank you much, very much, and thank you for having me.
You're welcome.